अच्छा, मैं यहाँ से लाइव कर रहा हूँ, ठीक है, आपने कर दिया ना? हाँ, इसमें दिखा रहा है, अब लिंक चेक करना होगा, जस्ट चेक द लिंक। लाइव मैंने कर दिया, डन लाइव। Yes, sir.
Hello.
Manish, sir, we are live.
Dr. Samsul, make me co-host.
I'm just stopping. Yeah, please start, Manish, sir.
Yeah, Dr. Rajgopalan, please start the proceeding. Share your slides.
Yeah.
Dr. Samsul, make me co-host. I will start the recording.
Okay. I think Ashok, please make me host again. I'll do.
Good evening to all of you. Welcome to people who have logged in from the organizing team.
Ravi, you can start recording.
Dr. Harshad.
Sir, Rajgopalan sir, please put it on play mode, actually, slide mode.
Yeah, I'm just trying to. Yeah. Can we start?
Sir, yes, sir.
Okay.
Yeah.
From the organizing team, a warm welcome to every one of you who have logged into this program. Today we are having our 9th module, which is on brachial plexus injuries and peripheral nerve injuries. I am Dr. Rajgopalan. I work in Pondicherry, and I will be the moderator for today's session. So this is our 9th module. We had 8 modules covering various other programs in the past. And this is our organizing team headed by our respected president, Dr. R.C. Meena, Dr. Shiv Shankar, who is our president-elect, Dr. Rameshan, who is the vice president, and Dr. Lalit Maini, editor. He is here with us. Welcome, Dr. Lalit. And Dr. Sandeep, our joint secretary. Welcome, Dr. Sandeep. Dr. Sanjay Dhawan, our joint secretary. And we have a Ioa PG training committee. I'm the chairman. Dr. Harshad Shah, Dr. Imam Ray, and Dr. Rajesh Goel are our members. Welcome, Dr. Shah and Dr. Ray. And now it gives me my privilege to introduce our faculty. And our coordinator for this module is Dr. Manish and Dr. Ravi. And the team behind all this, which makes it possible, is Dr. Ashok, Shyam, Dr. Huda, and Neeraj Bijlani. Dr. Reddy, Dr. Sunit, Dr. Vineet, I'll come to them one by one. And our guest panel is Dr. Lalit and Dr. Sandeep. Reddy is from Hyderabad. Is a consultant hand surgeon in the Sunshine Hospital. Is also the director of the DNB Ortho teaching program there. Is also the director of clinical research. Is an academic council member of the College of Engineering, Osmania University. He was awarded Wokhart Fellowship in Hand Surgery by Bombay Orthopedic Society and Johnson Fellowship, IOA, in 1990. Well, yes.
Thank you, sir.
He had state and national CME and conference in the last YSSCon. He also had conducted various workshops in hand surgery. He also conducted the YSSCon last year in Hyderabad, YSS TraumaCon, sorry. He had published many papers in national and international journals. He has been a postgraduate guide for more than 20 pages. Dr. Darshan is from Ramaya Medical College, Bangalore. He is the hand surgeon. He heads the department there. Has been conducting many workshops there, which are cadaveric workshops, which are very popular. He has done his F&B in hand and microsurgery. He is also a clinical fellow of hand surgery from Singapore. Got a PG diploma in tissue banking and also a PG diploma in hospital and health management. He has been a traveling fellowship in shoulder and elbow in the Royal National Hospital, London. Also in Institut Lamain in Paris. Lamain stands for hand, I think. I'm not sure about it. Welcome, Dr. Darshan. Dr. Sunit is the Joint Secretary of West Bengal Orthopedic Association. He is also Associate Professor in RG Medical College, Calcutta. Sunit is a very active person in the field of hand surgery, and he also was a panelist in one of our previous modules. Welcome, Dr. Sunit. Dr. Vineet is Associate Professor and is in charge of the hand clinic in Maulana Azad Medical College, New Delhi. He has done his fellowship in hand and reconstructive microsurgery in Singapore, in US Singapore, and he has also done his fellowship in hand surgery at Calgary in Canada. Welcome, Dr. Vineet. Our guest panel for today will be Dr. Lalit and Dr. Sandeep. I've already talked about them earlier. Welcome, Dr. Lalit and Sandeep. Lalit is the editor of the Indian Journal of Orthopedics, which will be known to all of you. There's no need to mention. He is also the president-elect of Delhi Orthopedic Association. He is the director professor at Maulana Azad Medical College, New Delhi. He is also the executive editor of JCOTS. He has authored several books and chapters in various books. He has numerous international and national publications to his credit. He has chaired numerous sessions in various conferences. He had many lectures in all over the nationally and internationally. He had also come to Pondicherry, where it was a big hit, where he delivered a very nice oration. Dr. Sandeep is our Joint Secretary, India Orthopedic Association. He is also professor and head of a unit in Department of Orthopedics in Hamdard Institute of Medical Science and Research, New Delhi. He has authored several books and chapters. He was awarded the Ruler Best Researcher Award in the year a national and international publication to his credit. Thank you all. Now we'll go to the program of today. Our first faculty today will be Dr. Darshan, and he will be talking to you about the brachial plexus injuries, clinical evaluation, and how he will manage these patients in brief. Dr. Darshan, over to you.
Is it visible, sir?
Yes, please carry on.
Okay. Good evening, everybody. Thanks for the opportunity, sir, and thanks the Iowa team for providing me this opportunity to present my work. Basically, I'll be speaking about the brachial plexus injuries. Hopefully, I'll try to simplify. The minute any orthopedician listens to brachial plexus injury, he says, "Okay, it's not our cup of tea. Just leave it." So basically, I'll try to simplify it. The outline of my talk is going to be on basic clinical presentation, how it presents, what is the evolution of the brachial plexus injury, and how the history taking, the examination part of it, and management of it. So why do we feel it's complex? Basically, we feel it complex mainly because of the anatomy. What is so complex to remember, and difficulty to examine these so many muscles which are supplied. It's almost 59 muscles, including the intrinsics and diaphragm. But we need to see what are the key muscles which we need to examine and identify them, how to pick them, locate the lesion. So to simplify, one is we need to revise the anatomy, technique of examination, and documentation. So the minute we see this slide, it gets really scary how to go about this thing. So basically, one thing we need to remember is C5, C6, C7, C8, and T1. These are the roots which are contributing this. And C5 is mainly responsible for the shoulder. C6 is for the elbow, that is elbow flexion. And C7 gives the entire extensors, that is the elbow extensors, wrist extensors, and finger extensors. C8, T1 is the long thoracic and supplies the fingers and the hand. So how to draw a brachial plexus quickly? If you need, these are the 3 Ys you need to draw. The step 1. The step 2 is connect these two proximal and the distal Y. Then you can go ahead with this thing. So once this much you draw, it's easy to know the basic structure as well. So once we start the examination, we need to know what are the structures which are arising from the roots, what are the arising from the trunk, and what are the structures which are arising from the cord, and further how it branches. Before that, we also need to know what are the mode of injury, because this is how we will be able to understand what is the main way or how to treat these structures. So it can be avulsion. The avulsion means These are three modes. One is the avulsion or the stretch or the rupture. So avulsion is basically how the roots, it is before the preganglion. These are the worst prognosis injuries. So where the repair cannot be done directly. Whereas in stretch, this is where the confusion starts and the partial injury will be there. Whereas in the rupture, this is postganglionic and the treatment modality varies for each of these. So when do we these type of injuries happen? Whenever the shoulder neck angle, that is this angle, is increased, forcibly widened by downward traction on the arm, the damage is imparted on the upper plexus, that is C5, C6, or sometimes C7 also. And if at all the scapulohumeral angle is forcibly widened, then the lower trunks are injured. So predominantly, you should remember the most common variety of injuries are the upper trunk or the global, which is what if at all the velocity is higher. So once we start seeing a patient, so broadly, this is how we can approach. Once we see a brachial plexus injury, so it can be either partial or complete. In partial, again, we're not going to discuss much about the complete injury because it's a flail limb and how to examine this is not much of this thing. Whereas we need to, this is what is a partial injuries. So that is what C5, C6, or it can be C5, C6 and C7 combination. But we need to assess whenever it is complete, whether does he have a horn room. We need to, that gives us an idea whether there is a avulsion component as well. So how could the patient present? Patient could present either immediately or after 3 weeks after the injury, or even after 10 months of the injury. So this treatment varies based also on the duration or the timing when they present. So immediately once we see, basically we give them rest and wait for the partial, because there is some component of partial recovery. So that is what, when we see it first, 1 to 2 months, that is what we see immediately. But after 3 weeks to 2 months, that is where you see the maximum recovery has already happened. But you need to elicit from the history that what was not there and what has been slowly you have been able to get means what muscles have started functioning after this injury. So after 10 months, again, it's very difficult to treat these. So basically, the nerve related procedures are not possible after doing for so long because it's the motor end plates die, and whatever the nerve reconstruction or the nerve related surgery we do, it may not help much. So we'll have to do a tendon or the bony procedures or the other free functioning muscles transfer. Physical examination, what are the things we need to assess? So what is the extent of the injury? As I told, it's partial or complete. What is the level of injury? Is the proximal musculature preserved? What is the severity of the injury? It's an avulsion or a rupture. What are the time-related changes? There has been any recovery. So once we start with the inspection, expose the torso completely. Don't hesitate because this will give us a lot of information just by look for the wasting. Scan for the myotomal sectors. When you are seeing for specific, as I told, C5 includes the supraspinatus, infraspinatus, and the deltoid. So you need to look for the wasting, compare with the opposite side. Whereas C5, which shows you can see the biceps, how is it? Whereas C7, the triceps and the forearm extensors. And C8 and T1 lesions are apparent when the hand is flail and the distal flexor or the intrinsics are absent. Not much points cannot be elicited. Precisely, it will be difficult to assess the level of inspection, means level of the lesion by inspection alone. So you need to go and assess what is the avulsion. Avulsion tells us the level of injury, but also how severe the injury, because the minute you say avulsion, that means the injury is much more severe. And you also look for some of these manifestations like wasting of the trapezius, whereas the avulsion of the lower roots, you can see where the Horner signs will be revealed. For example, in this case, the avulsion is scoliosis. The right side is affected. You can see this following the disruption of the posterior branches of the cervical, of the spinal nerve as well to the paravertebral muscles. And also, some of these points you can make a note, but they may not be characteristics. But dry skin in an anesthetic area is a postganglionic lesion, not a preganglionic lesion. And to assess the moistness also, you can see if it's not visible, you can slide a plastic pen over the skin and affected limb, comparing to the normal side, which can be used to test the sweating function of the limb. So basically, one has to follow the routine, what is mentioned in the Hutchinson's, like the basic thing, we need to see the bulk, tone of the muscles, power, MRC grading. The hand muscles is not the ideal way to MRC grade, but that is what you need to answer, at least grade 3 and above, we can tell them, because there are various modifications to assess these hand muscles, but commonly we have because MRC only. and the reflexes you need to check. So this one holds good for all the assessment of the brachial plexus. So then where is the thing? What is different? How do we rule out between the spinal injury and this injury? That's the sequence of examination is what. Once you broadly assess this, then you can try to correlate with the sequence. So you need to follow. One is the palpation. Next, once you start always, this is another dermatome which you need to see. Mainly, we know that C5 is around the shoulder area, C6 around the thumb, and C7 is the middle three fingers. That's the index, middle, and the ring, and C8 is the little finger. These are the dermatomes which they innervate. Sensory-wise, you can understand them. And this is what I was telling about the sequence of innervation one needs to. So you have to walk down the plexus. This is literally the word, you need to walk down the plexus. This is the sequence you need to. So what are the branches which are given by the roots you need to know. So this image might be a lot more clearer when you compare with this. So once you finish the sensory examination, you see the phrenic diaphragm. This is basically an X-ray, what gives you, because phrenic nerve involvement means even the C4, the higher level, is also injured. That is, you see the C4 is also injured. Then you go down. What are the branches which are supplied by the roots? So what are the nerves? What are the muscles supplied by the roots? C5, 6 and C7 forms the long thorax. So this sequence you need to follow to locate the level of the lesion. Most important. C5, C6, C7. So that is the long thoracic nerve, serratus anterior, you need to check. Then you need to check the dorsal or the rhomboid, dorsal scapula nerve or the rhomboids major or minor. You may not be, you're not able to isolate, but you can make out that whether this muscle is. So this is from the root which is arising. After that, you start with the supraspinatus and the infraspinatus. Then the axillary, that is a deltoid. Thoracodorsal, you can see this is dorsal. Once you go, then you come down suprascapular nerve. Then you come again, walk down. Thoracodorsal nerve you need to assess. Upper and lower subscapular, pectoralis, and finally these three methods, a radial ulnar and the mid. So starting with this sequence, what I was talking. So you need, how do you assess the serratus anterior, which is, I will speak, mainly we can leave these radial, median, ulnar, which can be covered in the subsequent talks. So mainly how to assess this is what I would also like to stress. Serratus anterior, that is C5, C6 and C7 now. The roots which we want to assess. So one thing you need to remember, a lot of these patients don't have the limb, the shoulder and elbow can be flailed. So you need to have tests or the techniques to examine them by giving good support. We cannot use the usual test what is mentioned when we are trying to test for a shoulder, may not be easy. For example, here we are trying to test for the serratus anterior. You need to stabilize the scapula. You ask the patient to push this thing, keep the limb on the table, ask him to go push it forward and try to pull it back. So you need to check and feel for the palpation is important. So simultaneously you need to palpate because other muscles also can start acting. So for example, in this one, so if at all, if you stabilize this thing, you have to hold it and also ask him to press forward, and you need to push it back from the front as well. This is one of the other ways where you can feel for the serratus anterior. The other ways commonly what we see is try to ask him to push against the wall and look for the winging of the scapula is what we usually see. But as I told, so many of them, shoulder will not be working and the elbow also, both of them will be flailed. So that is where the previously what technique I mentioned is useful. Support the table and ask him to push it. Then comes the dorsal or the rhomboids. This is quite simple. You can you have to stand at the back of it basically. Look for the symmetry of the both the ends of the scapular medial border and ask him to look the inferior border of the scapula and ask him to retract. First, here I'm checking, this is for the trapezius what I'm checking. Simultaneously, this is supplied by the spinal accessory nerve, which is essential if at all we are using as a donor. So you can see the bulk of the muscle here. So it is difficult to assess because trapezius can obscure our finding because the bulk of the trapezius itself forms a chunk there. So, but still you can check the trapezius first and compare it with, I'll show with one of the case examples subsequently, which we discuss. Tinnitus we need to check. So you need to ask the patient to sit and ask him, the red arrow is what we try to push it inside and he has to, because the supraspinatus basically provides initial 30 degrees of the abduction, or basically initiates the abduction. So that is what, so it has to be adducted fully, and then you need to ask to abduct, whereas you have to offer resistance to push it inside. That is for the suprascapular now. And then coming for the infraspinatus. Infraspinatus, again, you can see all these conditions, the limb will be flailed. So you need to support it, unlike other conditions. So you resistance, push it, try to press it down, and ask him to lift it and feel for your palpate for the infraspinatus with the other hand. Or the suspend his limb, ask him to lie down prone and try to lift it up. If at all you can stabilize or the other way is to stabilize his forearm, you hold it and ask him to rotate internally. Sorry, I mean to say, ask him to rotate externally, and you try to offer resistance on pushing it down. Next is the deltoid. Deltoid has 3 components. So one has to remember basically anterior, middle, and the posterior components. So here you have to try to bring it to the above if you want to isolate each one of them, and try to offer resistance in the 90 degrees. You can see the middle component. If at all you want to check for the anterior component, you need to try to ask him to, in 90 degree abduction, try to adduct it forwards and feel for the palpate for the muscles. Whereas similarly, posteriorly, you have to try to bring it back and offer resistance, look for the muscle there. So after this, we'll go to the posterior cord, that is the thoracodorsal nerve or the latissimus dorsi. Here you can ask him to push his shoulder down and try to feel for the latissimus. This latissimus dorsi forms the posterior bulk of the posterior border of the axillary fold. That is the latissimus dorsi, which you can feel. Basically, it's a climbing muscle. So I am trying to offer resistance and ask the patient to bring it down and look for that muscle which is standing out. If at all his elbow is also flailed, then the other way is you can ask him to lie prone and then ask him to reach towards his knee. Then you can see the muscles of that. That's the latissimus dorsi. Then comes upper and lower subscapularis. So here again, you ask the patient to rotate internally and you try to offer resistance. Ask him to lie down prone, which can be done in sitting posture as well. Finally, the musculocutaneous nerve. This is how you check for the biceps, because elbow flexion and elbow flexion is brought about by brachialis, biceps, and brachioradialis. But we need to isolate biceps. Biceps function is both elbow flexion as well as supination. So you have to supinate the forearm and ask him to flex the elbow in this, look for the muscle bulk and offer resistance. So you can see that's the bulk of the biceps. To summarize, we need to remember, as I told, C5 is for shoulder, C6 for elbow flexion, C7 for elbow, wrist, finger extension, C8 and T1 is for hand. So it is a sequence of assessment which helps us to localize these lesions. For further other muscles, you can click onto this channel to know it. There are other points once we are need to look for is the Tinel sign. So you need to note the Tinel sign, where is it maximum, and this has to be serially recorded in subsequent visits as well. And most important thing, it's a distal progression which you start palpating from distally and progress towards, go towards plexus and assess the exact site of the pins and needles or the shock-like sensation where the patient feels. The other sign of reinnervation is the muscle tenderness. Look for the scar on the chest, where if at all they have been polytrauma and ICD tube has been inserted, because we can use intercostal nerves also for donor or the reconstruction of the brachial plexus. So NCS and EMG, when do we do it? A baseline examination should be done for the NCS and EMG by 3 to 4 weeks. And SNAP is what we need to look for, whether it's avulsion. If it is preserved in case of avulsion, because a ganglion will be there, which acts as locally there. And an intact SNAP in the presence of a dermatomal anesthesia is a pathognomic of root avulsion injury. In post-ganglionic injury, the sense axons will degenerate and SNAP will be lost. And MRI is another investigation which can reveal traumatic pseudomeningoceles, large neuromass, and rootlet abnormalities associated with inflammation and edema and mass. So immediate MRI may not throw you so much because it shows is edema. So we tend to wait for a month unless we are suspecting any other cervical spine injuries as well. Next comes the timing of the surgery, because most of the time we see what is that critical time we need to. 2 to 3 months is a critical window where we wait for some amount of recovery, because I told you the third one was that the stretch injuries, which are always ambiguous, where the continuity is seen on the MRI, but whereas the motor functioning is not there. So that's why we tend to wait for 2 to 3 months after the injury. And when there is no further improvement, by improvement in the sense there is no new muscles which are recruited, same muscle having the strength but not increasing in strength is different, but no new muscles are recruited, that is where we have to intervene, and usually it is around 2 to 3 months. So treatment options, when we start for treatment thinking of this, so we need to localize the lesion clinically, and either we have to do reconstruction or the nerve transfers. Earlier, we could say, means in the exams, whenever they used to ask or something, you could say a brachial plexus repair and get away, but it is not so. Now, reconstruction, and you need to know a few points about the nerve transfers as well. Reconstruction is done for a rupture, whereas nerve transfers can be done when there is an avulsion injury and when they present in the critical period, or that is initially. So what do we know about nerve transfers? Nerve transfers are neurotization involve a repair of a distal denervated nerve element using a proximal foreign nerve as a donor of neurons and their axons, which will reinnervate the distal targets. So this is something like a tendon transfer, but using a nerve, but we have to do it much earlier. There's a time limitation for nerve transfer. So you can, in this case, we have to sacrifice the function of a lesser value donor muscle. Function is not always lost, but partially weak could be, and to revive the function in the recipient nerve and the muscle that will undergo reinnervation. Indications for nerve transfer in the upper are usually either brachial plexus avulsion injuries, where no proximal nerve is available, or proximal nerve injuries that would require a long distance or the long regeneration with a graft. Commonly used donors for nerve transfer. So again, once you start classifying, it's either extraplexal, intraplexus, or fascicular. Fascicular in the sense we take only few fascicles. Extraplexus is most commonly used as spinal accessory nerve, phrenic nerve, and intercostal. Intraplexal, that is C7, we use the C7 nerve root, and fascicular is, as I told, few fascicles only. Not entire nerve is not injured. It's only a part of few fascicles which are taken. For example, then how do we go about this? Is what is a typical procedure of a nerve transfer which undergoes. This is a skin incision, what we do on the neck, L-shaped or the curvilinear incision. This is the incision on the arm. So once you expose them, then this is what we identify. So here you see C5, this is the head end, and this is the clavicle, this is the C6, and this is the Erb's point, and the first branch which comes out is the suprascapular nerve. So how does a normal stimulation look like? So when you are trying to look for that as a C5, once you start with a nerve stimulator, I'm stimulating the nerve root. That is a C6 which we are stimulating. Then I try to stimulate. This was a case where we explored this. He had an infraclavicular region, whereas proximally there was neither root rupture or avulsion. That's a suprascapular nerve, and that's the divisions, anterior and posterior division, which we are stimulating. So dissection in the arm. Once you can see all the nerves will be exposed here. A closer look of these nerves. So you have a nerve here. I have put a vessel loop. This is the ulnar nerve. This is the median nerve. This is the musculocutaneous nerve. This is the biceps. You're seeing on the medial aspect of the arm. So this is how it is. So we need to confirm them whether they are functioning or not. So you start using the nerve stimulator again. So that's first is the ulnar nerve I'm stimulating. So you can see the flexion of the wrist is more towards FCU. Now it's a median nerve. So the flexion is more towards the radial side. After this, I stimulate the median musculocutaneous nerve. You can see that there's no stimulation at all, even after trying an attempt to stimulate. So you can confirm that the musculocutaneous nerve was injured at the lower level, whereas the proximal side, it was probably intact. So what are the functions lost in a partial injury? It is a shoulder abduction and the elbow flexion which is lost. We need to try to restore them. An avulsion injury. Whenever for shoulder abduction, there are two nerve transfers which we use. That is, we use a part of the long head of the radial nerve. The radial nerve giving a branch to the long head of the triceps is used as a donor for the axillary nerve. That is the nerve transfer which we do. That is radial nerve branch of long head of triceps to axillary. Now, And the other nerve transfer which we do use for suprascapular nerve, that is the spinal accessory nerve, vesicle, we use it for the suprascapular. And to restore the elbow, there are two nerves which we use. One is the median nerve and the ulnar nerve. So one of the vesicle of the ulnar nerve, that is a small vesicle of the ulnar nerve, is given branch to the musculocutaneous nerve for biceps, and the small vesicle of the median nerve for brachialis. So these two will restore the elbow flexion. So this is what has been done in this case as well. A branch of the median nerve is given to the brachialis, and branch of the ulnar nerve, here is the ulnar nerve, is applied to the biceps. So one just case I'll just show you. This guy had a left side clavicle fracture. He presented almost 3 months after the injury with a left side brachial plexus injury where C5, C6 was injured. But he had some amount of trying to assess the rhomboids in the trapezius. You can see this, there is asymmetry here. The trapezius is trying to mask it, but still you can see the bulk is formed here on the right side, whereas in the left side, the bulk is not there, and the medial border of the scapula is away. So before surgery, he had the clavicle fracture as well. So this was the surgery we did finally: spinal accessory nerve to suprascapular nerve, radial nerve to the axillary nerve, and this is called Oberlin's transfer. He's a guy who described this procedure, these nerve transfers, and also clavicle fracture fixation with the bone grafting. This is what the process. So fixed at the same setting. So 4 months after it was a similar, 4 months after the surgery, you can see that. This is for comparison. Left side, his elbow has started flexing. The bulk of the biceps has started contracting, and shoulder abduction has started almost 30 degrees. The results these things will be progressing even up to a year. So subsequently, when you see him, this is 9 months after follow-up. I can see the tone, the bulk is better, he's able to abduct better. There are no deficits, even though we have taken few vesicle from the median and ulnar nerve. This is what is trying to show there. There's no weakness in the radial, and shoulder abduction has gone up to 90 degrees. And elbow flexion, even the flexion and the abduction has improved. And is able to reach his mouth as well. And the clavicle has gone to unite well. You can see his rhomboid still not acting, but because of the rest of the shoulder stabilizers are better. So you can see that swinging is slightly present, but still rest of the shoulder stabilizers are working well. So that's why he's able to do these. So usually in partial lesions, so you can expect good recovery, whereas in global, the assessment part is hardly, not much. So that's why I chose one of these cases with a partial injury where you can see the progression as well. Thank you.
Thank you, Darshan. Darshan, I was just thinking, the slide with the link for the examination, if you can just keep it for a little more time, those in the audience who want to jot it down can do it. Meanwhile,
yes, sir.
I will like Dr. Beneath, Dr. Reddy. If anything more you want to add, or any clarification, or any questions to Dr. Darshan?
I have a small question, not regarding exactly the clinical examination and that part, regarding the management part. Because many a times these actually brachial plexus injury comes as a polytrauma patient. So many a times you will get you got the clavicle fracture patient was there, and there was an open injury. So I think the main dilemma was whether to manage the brachial plexus injury first or to deal with the bony injury first. Because I usually belong to those orthopedic surgeons who actually run away from the sort of brachial plexus injury. So I referred that case to plastic surgeon, and my thought was, if the brachial plexus is not going to give a good functional outcome, there is no point in reconstructing all those big fractures, open fractures and everything. So I think and the plastic surgery wanted to get the bone reconstructed first. So what is the main protocol on those sort of situations?
So thanks for your question. Usually whenever we see these things, so unless an open or a penetrating injury of brachial plexus injury is there, we don't intervene at that time. So we go ahead with fix all our bony management, finish that, and then wait for 2 months for the recovery of the nerve, because many of the times, a lot of nerve fibers will be under stretch. So there are a good number of nerves which are under still partial injury. So we allow them to recover. So 2 to 3 months is a time to intervene. So major indications for these two is basically a penetrating or open brachial plexus injury is the only thing where we operate immediately at that time. So fix all, go ahead, finish off your bony work, and then
two things. Now, first thing is normally in my experience, we don't keep a global plexus palsy in the exam. So it's only C5, C6 most of the times. Erb's palsy we put it. Now I have two questions here to help the postgrad. One, Erb's palsy in an adult. If the case is there of 3 months duration. Now the usual questions we asked him is what investigation you would like to do and how do you proceed. So what's your answer for that? That's number one. Number two. Same C5, C6 lesion which see in children, and then these people they keep in the exam around 9 to 10 years of age. So in addition, so that is a long neglected C5, C6 in children. So those cases are again kept. Again, there, what are the investigations? The examiner usually asks them, and what are the options of treatment? Can you elaborate on these two things? Or C5, C6 in children of 4 or 5 years duration?
Correct, sir. Fine, sir. Okay, sir. First thing is coming to the nomenclature. Erb's palsy is the term used for usually pediatric brachial plexus. Adults, we use the term C5, C6. That is what we have to, but it's commonly used as Erb's even in adults, which is not advisable. And as your question you asked, when we see C5, C6 around 3 to 6 months, the basic investigations are, one of the things is you need to take a chest X-ray in full inspiration and expiration. That is to tell us how the phrenic nerve or the diaphragm is functioning, or if there is any intercostal injuries there. Second thing, because that can be used as a donor if at all we want to reconstruct. Second thing is MRI to localize the lesion, whether there is avulsion, a rupture, or what are the roots which are involved. That is the second thing. Third thing is nerve conduction study and EMG. Usually 3 to 4 weeks after the injury is what is the preferred time which we do it. But it can be done to serially monitor as well. So that is where these are the 3 main investigations which we ask for in the example that we commonly do it. Coming to your next question of the children. When we see in a children of after 4 years of this thing, basically that is not the time to do any of these MRI for the nerve, because we are not going to address nerve at that age group, because it is all the secondary deformities which has formed the child has. So there is no point in doing an MRI of the brachial plexus at that time. So what we need to assess is the range of movement because most commonly, as sir told, it's the upper plexus, which is the C5, C6, and which has partially recovered, and child will have the secondary deformities or which would have developed at that time. So we need to, that is the abduction will be only little bit, elbow flexion will be an issue little bit, or external rotation because shoulder is the most common joint affected in a partially recovering Erb's palsy in a children. So we need to document more of these. And the investigations what we ask in these children are mainly much of the things are by examination. Other than the shoulder X-ray we ask, and we can ask for a CT of the shoulder if at all we are planning for the corrective surgery or this thing. I have to look for the glenoid morphology and how the muscles is. So there is no role for MRI at that age group, and no role for NCS or EMG also at that age group. It is because we are all going to correct the muscle and the bony deformities, or the soft tissue rebalancing procedures are the ones which we are going to do.
One more question.
So in children, when we do it, usually soft tissue procedures can be done even up to the 8 years or this thing. But whenever you want to plan derotational osteotomy, it is usually after 9 to 10 years is the lowest limit, or even much more later. Because if we do it earlier, because there is a good amount of remodeling which can happen if at all if we do it earlier, and the correction what we have done is lost. Derotation osteotomy most commonly. But whereas soft tissue rebalancing there have been instances where you have been doing at later date also. But one thing we need to remember whenever we are doing a derotation osteotomy, how badly the shoulder joint is deformed or subluxated, because irreconstructible shoulder joint per se is an indication for the derotation osteotomy, because we cannot do much more changes with either by glenoid osteotomy or soft tissue rebalancing. That is where we need to go for
probably soft tissue reconstruction beyond 8 years, bony reconstruction.
Yes, sir. Yes, sir.
Yeah, because these are the 2 questions we usually, this is what we expect from the postgrad, not more details about what transfers they do, but at least they should know when to correctly send it for a reconstructive procedure.
Yes, sir. Yes, sir. Thank you.
Dr. Darshan, can you stop sharing the screen, please?
Yes, sir. Yes.
That were two very relevant questions Dr. Reddy asked for the students' sake, because these are the common questions and this is a common case too. Dr. Vineet, anything you would like to add?
No, not just students, sir. Actually, when we see so many orthopedic guys who are not avoid these brachial plexus, we end up seeing a 8-year-old child, 7-year-old child doing an MRI of brachial plexus and coming to us because somebody has put the word Erb's palsy, and eventually MRI of brachial plexus is done.
I had a student who said in an 8-year-old, he says he wants an MRI of brain. Now what do I do?
Okay.
Because he thinks neurological children means he's only thinking of cerebral palsy and he wants an MRI of brain. I didn't know what to do with him.
Okay, sir. Okay.
Very true, Dr. Darshan. But we are concentrating on the students. That is why I said that. But I can say that even my knowledge will increase after this. Welcome to Dr. Shivshankar, our President-elect. Welcome to see you. I'm happy to see you. And
Thank you.
And Dr. Lalit. Yeah, Dr. Lalit, you are there. Can anything to add?
Yeah, definitely, Dr. Darshan. That was a very excellent lecture, and you emphasized on simplifying it. Thanks a lot for that. It would invariably be a short case in an exam. So in a short case, the first question is asked is, what is your diagnosis? So could you help the postgraduate in telling him how he should spell out the diagnosis of a brachial plexus injury patient? Let us take an example of a C5-6 injury in a 3-month-old who also had a fractured clavicle. So how should he spell it out?
Okay, sir. So basically, put it as 3 months old, right side or left side brachial plexus injury involving C5-C6 root with avulsion or rupture, whatever is there, you need to mention at this thing, and with whatever fracture is there. These are the words which we need to use, because timing is very critical. Usually for so many other things we don't mention, but whereas in brachial plexus, you have to put that because the whole plan changes this thing. So 3 months old, brachial plexus injury, what site, whether it's rupture or avulsion, if at all you are able to point out in clinically, and then associated fractures, whatever he has.
I would also like to add whether it's recovering or not recovering.
Okay, sir.
Because that makes the whole treatment changes. If there is some grade 1 or grade 2 improvement, you can rather that. So in any nerve injury, we always put site, type of injury, whether it's recovering or not recovering, whether if it's not going to recover, we have tendons or others to do a reconstructive surgery. These are the 4 things in any nerve injury I always adjust. When I talk my talk, I'll tell you more details.
And another thing I wanted to know, quite often the students are asked that, how do you take care of a brachial plexus injury when you are waiting for a decision making or you are keeping him under observation? Meaning, what would be the other points of care, do's and don'ts or splints or any manipulation exercises? So what should be the non-surgical care for a brachial plexus patient?
Okay, sir. Initially, the first time once you come into contact us, you need to give him, because he'll have a lot of pain. You need to take care of his pain. Analgesics is important. So we immobilize that limb for 2 weeks. That's with an arm pouch. And after that only we start, once his intensity of the pain comes down, then only we start with the mobilization so that he doesn't have any stiffness. By 3 or 4 weeks, we plan for the other nerve conduction study or EMG. The other most important thing, one more important thing, which whenever we see a brachial plexus, always don't, in acute trauma in an emergency setting, always feel for the vessels, where so many times that get missed out and it's seen only much more later, but the limb will be surviving with collateral circulation or something. So that is one thing which most of them can miss, either the fracture or a vessel injury also is usually messed up. So during this is what, and we need to have a serial follow-up of every month, so that what is the progression, what was there and what is recovering slowly, because that will help us to understand whether it is recovering from that and then when to intervene surgically. Role of splints, if at all he's got C7, then try to stabilize the wrist as well. But there is no other much of the splints which we use for either elbow or shoulder other than the arm pouch.
Dr. Ray, I will come to you, Dr. Ray. Please hold on. Dr. Sandeep, anything you want to add, or guest panel?
I think.
Then I'll come.
Yeah, definitely. I would like to add something over here. I should congratulate Dr. Darshan for a wonderful talk.
And rightly said, many of the orthopedicians, they either miss it or they don't want to touch brachial plexus injuries. So through this platform, I would like to tell the postgraduate students that they should know the basics of the brachial plexus. Nobody is going to ask them the hi-fi questions in the exam that how you are going to do the procedure, how it needs to be done. So the basics they should know, and the anatomy of the, once they know the anatomy and the muscle structure and how to assess an exam, I think in the brachial plexus, they'll pass through the exam. Yes. That is the most important, the message which I would like to pass. They should not get afraid. They should not get tensed that brachial plexus injury case has come. Now we are going to fail. So that is never, because if the case is difficult, the examination will be easy. So if the questions are easy, the examination is difficult. So it goes like that. So nothing to afraid of. But yes, we need to examine, as Dr. Darshan has point-wise in sequence, he has told that this we need to examine, then this, and the concept that you should examine, you should diagnose, and you should know the basic principles of management. I think that is the best thing, and it's a wonderful talk, and I should congratulate Dr. Darshan for that.
Thank you. Thank you, Dr. Sandeep. That was really a good message for the students. Dr. Vinit, you are not in between. Anything to add? Anything to more to say on this matter?
I think Dr. Darshan has presented very well, and his experience is so much greater than mine in brachial plexus that I don't think I can add anything on this.
Thank you, Dr. Vinit. Dr. Ray, something you want to add?
No, in our earlier days about the investigations, is there any role for myelogram in detecting the level of lesion?
No, nowadays no role of myelograms.
No myelogram.
No, not at all, sir.
It is in some textbooks. It is there.
Earlier, yes, sir. Even now it is mentioned in a lot of books. It's mentioned, but we don't do it, sir. In fact, we can do a 3-test MRI.
Contrast MRI will give pseudo-meaning.
Contrast MRI
will give pseudo-meaning.
Yes, sir. Yeah.
So, and second thing is that in prefixed brachial plexus injury, is there any chance of diaphragm paralysis?
Yes, sir. That's why we assess for the because sometimes it's just not prefixed, because phrenic nerve itself sometimes gets contribution from C5.
C4, sometimes
yes,
maybe.
There is definitely a role of that thing. That's why we need to take, because if at all we are using phrenic nerve for donor and some other nerve is also, or intercostal nerve, if we take off both the nerves, then that part will be totally collapsed. So definitely there is a probability of this phrenic nerve injury, sir.
Right.
Shah, anything?
There are a lot of things. Please. This is such a complicated matter. I think Darshan has covered up everything and made it so interesting that everybody will keep listening it and looking into it many a times for revision. Good, Darshan. Well done. Happy with you.
So before we end,
questions can come up. The thing is, when you do a clinical examination, brachial plexus, where do you draw the line? You have given some of them for the long thoracic nerve, this, that, and all that, which are peripheral nerve injuries. You have UMN. Okay, let's start from the brain. The brain, the cord, the brachial plexus, and then peripheral nerve. Okay, where do the peripheral nerves start and where does the brachial plexus? So you have a problem that all the postgraduates must know, that every nerve